Okay, then welcome everyone to the second edition of our devotion discussion event. Today, Ibone Olza is going to present on a case in Spain with a CEDAW ruling, and we'll learn all about that in just a bit. Just as a general agenda, Ibone will introduce herself in a bit. Then she will introduce the case for about 20, maximum 30 minutes. And after that, we'll have another half an hour approximately for discussions, and you're warmly invited. If you have questions, take notes, and please ask your questions after Ivone's input. I'll have a look for raised hands, both on the video, and if you use the little reaction hand, I'll have a look for that as well, and call you up then. And I hope that we can engage in a lively discussion. And I'm sure there's much to be said about this. Ibone, the floor is yours.
Okay, thank you, Katharina, and thank you everyone for being here. And thank you to this wonderful group of Coast Devotion for having the opportunity to discuss this case. I'm Ibone Olza. I'm a child and perinatal psychiatrist, currently living in Madrid. And I'm also an activist. I'm one of the co-founders of El Parto es Nuestro, which is Spain's oldest activist group for human rights in childbirth. So I was very interested in sharing this case because I think it brings many issues of great interest to all of the people doing research around childbirth, and also for the clinicians and also for the activists. So you might have heard a bit about this case already, but I'm willing to give a short introduction to the case, and then we can discuss, because I think this case raises many issues, and I'm really happy to have this opportunity. So this whole thing starts last July, on July 14th. United Nations CEDAW, which is a committee for the elimination of violence against women, published this on their webpage, a press release: Spain responsible for obstetric violence. And that was quite a shock for us to see it, quite a day. And to get back, remind you that this is the Committee for the Elimination of Discrimination Against Women. It belongs to United Nations. It's made, I think, of 23 international experts on women's rights and against experts on violence against women. And all what I'm going to share, it's actually extracted from their website, okay? You can, in this link, you can find the report. And previous to this sentence regarding Spain, back in 2019, they already published this report that is central to understanding of this case. The report by the Secretary General was called A Human Rights Based Approach to Mistreatment and Violence Against Women in Reproductive Health Services, with a focus on childbirth and obstetric violence. And the fact that the term obstetric violence was included in the title made it quite powerful. And this is a must read, I think, for anybody who wants to work with women who've been who had traumatic births. Okay, so this would be like the introduction, but I think it's very important to have read that report to understand this sentence. So this is Nahia's birth story, and as I said, all what I copy pasted it is from the same website. You can download it right there. Okay. Nahia gave birth 10 years ago, in 2012. She presented a birth plan. She lives in the north area of Spain, in the Basque Country, and she attended a public hospital. And before delivering her baby, she had already presented this birth plan where she had stated that she didn't want any drugs to induce or accelerate labor, that she wanted to be informed and ask for consent before any interventions, that if she was going to have a cesarean, she would want the baby to be with her immediately. And if this was not possible, she would want the baby to be with the father. And most of all, the baby should not be bottle fed. So having presented that on July 9th, she broke water, so she went to the hospital, and that's when she had the first vaginal examination. The hospital's protocol says that you have to wait 24 hours before inducing labor in a case like this. But in her case, at 4 o'clock in the afternoon, they said, we're going to start induction already. And when she says why, they tell her, well, because we did not induce at night. So she started to question these decisions. Sorry, I'm having a bit of a problem here with the... Okay. She asked for information, but she didn't get the information she wanted. So she did not consent to this induction of labor. She also asked to eat something before all this process would go on, and she was denied. She was not allowed to eat anything. Along the following hours, more than 10 vaginal examinations were performed. And at some moment, the midwife told her that her labor was stopped and that they were considering to induce her. You can see here in yellow the sentence, the author, because in the UN report, in the CEDAW report, it uses the word author when referring to the mother, okay, or to Nahia. So in some places, I did change the word author for Nahia or mother, but this is all taken from the original sentence that you can download yourself in many different languages. So, so when she said, why would you want to do a cesarean? She was starting to cry. She was very afraid. And she says, no, please wait. And they tell her, yeah, we're going to do a cesarean. And when she asked for more information, she reports that they treated her like a little child. They told her, oh, calm down, we're going to take care of you. So at 10 o'clock in the morning, the cesarean began without her consent. And they didn't allow her husband to be present. And these are her words. I think it's very important that we read these words, okay? So this is her testimony. She says, I was placed on the operating table like a doll. No one introduced themselves. No one spoke to me. No one looked me in the face. No one bothered to try to calm me down. I was crying a lot. They placed my arms out to the sides. The operating room was full of people. It was like a public square. They ignored me and shouted to each other, the placenta container is missing, and where is the baby's tag? I was there alone and naked, and people were coming and going. The door kept opening and closing. They were talking about themselves, about their business, what they had done over the weekend. They were talking without caring that I was there and was about to give birth to my son who could only be born once, and they did not let me experience it, okay? And right after they took the baby out, they took him away. They separated from her for no good reason. And she only got to see him. And then they brought him back a bit later, clean and dressed and washed. And they told her, kiss him. You know, she was ordered to give him a kiss. But they brought her close to her, and then they took him away very quickly. And when she asked them to bring the baby to the father, again, they told her, calm down, little girl. You know, in Spanish, they use this expression, chavalilla, which is like little girl, like very despiteful. It's all over. So they didn't say anything else to her. Later on, she asked for the baby to be brought to her, but he was not brought back to her. Actually, he was bottle fed, despite they had stated that they wanted him to be breastfed. So a few months later, she went to her primary care doctor because of symptoms of anxiety. And about 11 months after the birth, the psychiatrist from the public health system saw her and wrote in the notes that she had a postpartum post-traumatic stress disorder. And he prescribed her some medications, okay? After this, she decided to file a claim against the Basque Health Service, asking for responsibility for medical malpractice. And she stated these things, that she was claiming for, because they had started the induction of labor way too early. They had not followed the protocols. They had done the cesarean without informing her or seeking her consent. They had not, the fact that the cesarean was done by residents and medical students against her wishes, that she had been separated from her newborn, that they had bottle fed him, and then the entire trauma associated with this and the harm this had caused to her, her family, and everything. So I actually did see her, met her for the first time about an hour and a year and a half after the birth in November 2014. I got to do several interviews with her, and I did provide a report that it's included in the CEDAW report. Okay, so what you see here, the specialist who did this was me. And I wrote that I confirmed the diagnosis of postpartum post-traumatic stress disorder. And I stated that this disorder was the result of the way in which she had been cared for, or lack of care actually, during the birth of her son, and that this could have been avoided with better care. I stated that if she had been treated differently throughout childbirth, she certainly would not have exhibited such intense symptoms, nor would she be still suffering that much. So I did, my opinion was that there was a direct relationship between the way she had been treated and ignored and the psychological injury. And so she went to court with all this, and also with a report from a gynecologist and from a midwife who also had access to the clinical records and who agreed that there was not an indication for an urgent cesarean, neither for an urgent induction of labor. So this was all assessed very carefully and taken to the court. So when she went to court, all of us, the gynecologist and myself, we were not allowed to speak. And finally, in October 2015, the court dismissed her application. And it's very interesting because in this judgment, the court said that the birth plan was only an expression of wishes, that it had no legal power, and that she had had a correct care, and that labor is a natural process where informed consent, look at these words, has no meanings, since the will of the patient can in no way alter the course of events. And it was very shocking for us that in the court sentence, they didn't listen to the psychiatric report. And they said that according to another doctor, the author's experience was the result of her own character, not of the treatment received, and concluded that there was no evidence to support the author's interpretation, which was a matter of mere perception. And this is a key issue because we find this in many cases of birth trauma, and we also find it in on the research. Just look at this recent paper. I mean, what we find in many papers is how this is a pattern of blaming the women. There are studies like this where they say that it's the personality risk factors of the women that can cause these post-traumatic stress symptoms, and that maternity care providers could educate women about the unique roles of high perfectionism and intolerance of certainty during antenatal birth preparation. So we find these ideas that we call women blaming permeate the clinical practice of many doctors still. And this is very obvious in this case, how our reports of the association between the mistreatment and her symptoms were totally ignored, and it was all blamed to her personality and perception. So after reviewing all this information, 10 years after the birth, this July, it came out, this report from CEDAW saying that the committee makes the following recommendations to Spain. And they said, concerning the author or the mother, in this case, Nahia, the CEDAW recommends that they provide her with reparation for the damage, with appropriate reparation, including adequate financial compensation for her physical and psychological health. And besides that, they also provide some general recommendations for Spain that include ensure women's right to safe motherhood and access to appropriate obstetric services, that they conduct research into obstetric violence, look at this, that they provide obstetricians and other health workers with adequate training on women's reproductive health rights, and that they ensure effective remedies for women whose rights have been violated. So this was very interesting because when this came out this summer, last summer in Spain, 3 days after, the Basque Health Service, the public Basque Health Service, published a note. And this was very shocking for us because they stated again that the assistance provided in this case was according to the medical protocols, that the performance was adequate and correct, and there was no problem, and that they had not been informed of the procedure before the United Nations Committee. They published this note. So at this moment, this brave woman, Nahia, decided to go public with this, and she decided actually to give her name and offered some interviews to the press. So this came out in one of the main Spain's newspaper. It was a very good interview where they showed that, in her words, this was the title of the interview, that she could not remember almost anything from the 3 months following the birth because she was so traumatized. And the fact that she came out public probably helped a lot, because then this was in a lot of newspapers and interviews. So it was really a big thing. And it also had some international echo, and this is in the news in France 24 and in other European media. It also came out, this campaign to bring obstetric violence out of shadow with regard to this case. And then in the fall, El Parto es Nuestro, with another association from Spain for feminist maternities, wrote this manifesto against obstetric violence. And it was a big success because it was signed by over 60 feminist associations from Spain. So it was all also in the social media. We asked for other women to share their stories of obstetric violence and to ask for responsibilities. And it was like an educational campaign also against obstetric violence. So again, this continued on the media. The Association of Doctors again came out saying that there was no obstetric violence in Spain, in spite of the sentence from United Nations. I published a big opinion paper on an important newspaper, and others did too. So this is just a small sample. And then finally, like, the best news is that 2 days ago, this was also in the news in Catalonia, the government has created the first working group from the government to face obstetric violence and to solve it. So there has been, this is just a hint, there's been many initiatives and a lot of debate going on in Spain around obstetric violence because of this sentence. There had been another sentence also condemning Spain for obstetric violence a couple of years ago, but it didn't hit the media that much. So the issues for discussion that I want to bring here, and I will end it here now and let you all share your thoughts, is on this. It's on the interface between post-traumatic stress disorder, obstetric violence, and human rights in childbirth. And there are several questions that I'm going to leave here because I think some of you might want to bring some feedback. But for me, these are, first, when we talk about birth trauma, what are we talking about, you know? Is it the birth itself that is traumatic, or is it rather the mistreatment, the abuse, the obstetric violence that we call, that causes a trauma? Because then maybe we should reframe it. Instead of talking about PTSD following childbirth, maybe we should start talking about PTSD following obstetric violence. You know, and I think this is something we really need to think about in the research group as in discussed action. And we also have to consider something that I think has got little attention so far, is the role of the restorative justice in treatment. Because we are used to seeing papers about treatment for PTSD, but many women, like Nahia, like many of us, become activists to do something to stop this violence. And this can be very healing for many women, but it can also be very tiring, very consuming. We have to remember in Nahia, it took 10 years for the sentence to come back. And most women who do experience such mistreatment will not have the energy, the resources, the money, the education to get this far, to get to United Nations. But I think when we think and research treatment models for obstetric violence, we have to think of including restorative justice, because what most women want actually is the harm to stop, that no other women or baby will suffer this harm. And that can be a very important part of treatment. Same as activism. And so activism sometimes is a way of post-traumatic growth. So I think there are many issues here that I want to discuss with you, researchers. So I will be very happy to stop here my presentation and listen to your thoughts, your questions, your reflections, whatever you want to share. Thank you.
Thank you for first. And oh my God, I didn't know you were a psychiatrist, so you know more than us. You know how it works, and I guess you see a lot of women that suffer from a bad birth. I don't know if we could find a psychiatrist in Cyprus to sign something like, you know, that it is related. It's a very small country. Everybody's connected, the medical community.
Can you repeat again which country are you in? Sorry, and introduce yourself.
Cyprus.
Okay. Okay.
Yeah.
Jota, can you shortly introduce yourself, who you are and who is your organization? It's all right.
I'm Jota, and I live in Cyprus. I come from Cyprus, and I'm the secretary of Birth Forward. It's an organization that tries to bring in light all. If I can say, like, obstetric violence is one of the things we are trying to battle, but we try not to do it like full force, kind of, because at the moment we still need the medical community, because most women, obviously most women still or their environment, like their family, they still trust the doctor. So and we had in 2017 we did a big campaign supported by the ministry, supported by the president of Cyprus. It was big, and it was in the news, and it was about cesarean, because in Cyprus we have so many cesareans. And the Gynecologist Association, we had like a band and didn't talk to us for a couple of years until 2019, because we just did a campaign saying that the obvious that it doesn't have to be like 60% cesarean. Just this. So yes, we are trying to work by collaborating and teaching women their rights, and working with projects with doctors and medical students and midwife students, just trying to. But honestly, I admire these women. I admire her so much, because it is very difficult to do what she did, to endure this much, especially when she had a negative response from the court.
Yes, you're right. She was very brave, and also her lawyer, Francisca Fernandez, who took it so far, was really, really courageous to be so patient. We're talking about waiting for 8 years for this resolution. So yeah, it takes a lot of courage, but we hope it can help others. That's why we really want to share this news. Katharina.
That's what I wanted to ask about. So it took 10 years between the birth and the CEDAW press release, which is not a ruling, right? It's just a CEDAW. What is it? It's a statement. Because it's not legally binding. Like what status do these recommendations, and does this CEDAW outcome actually have?
I think they do have some power. And in the other case, in the previous case in Spain, they also stated that the woman should be paid, and the Spanish government hasn't paid the woman yet. But I think it does have, I'm not a lawyer, so I'm not an expert on this part. It's not, I don't know the exact name for it. It's not, it has some power, because then Spain is in that committee and Spain is signing agreements. So this is going to continue. And I know there are 2 more cases that are almost at that level, that from Spain, that are now being reviewed by CEDAW. So we're expecting 2 more sentences in the next couple of years, maybe. So I'm not exactly sure about the legal power, but I know it is some kind of condemnation.
Yes,
because
yes,
where
of
it comes
course. But like so it's not legally binding that it's like a ruling against Spain, or that CEDAW has any kind of power to, I don't know, fine Spain or anything else. But of course, Spain has signed the CEDAW treatment. And so Spain has to go before the CEDAW committee in Geneva every 4 years. That's the normal reporting cycle. And are you in contact with the group that go to Geneva to those CEDAW hearings when it is Spain's reporting cycle? Because I think that could be really powerful to go to Spain there and say, hey, we still have these recommendations out there and they have not been responded to kind of
I am not in that group, but our lawyer, Francisca Fernandez, she is.
Good.
She actually went to Geneva to one of these meetings a few years ago, and I know she's in there in collaboration with them.
Because I think that's the thing about CEDAW, that you need incredibly long-term resources, because even after these sentences, then you have to go back to the Geneva and say, hello, we have these recommendations. They still haven't, done this. Could you please remind them again? And it takes so long.
That's why we did this effort for all feminist associations in Spain, whether they were related to pregnancy and motherhood or not. I mean, we think it's very important that all feminist groups know this sentence. It's we use it to educate them also.
Kim.
Yes, thanks, Katerina. Yeah, I thought that was a really interesting and sort of powerful presentation. So just to say who I am, my name's Kim Thomas, and I work for the Birth Trauma Association in the UK. And so we're a charity that supports women who've had traumatic birth, and many of whom have PTSD. And that story you told was actually very familiar. It's the kind of story we hear a lot. And I was kind of interested in your question about PTSD as a result of obstetric violence rather than, say, PTSD following childbirth. And I think that's a really interesting proposal, because it kind of shifts the blame away from the woman in a way. Good, because as you said, there's this kind of tendency to say, oh, the woman's expectations are wrong, or maybe her personality was defective in some way and she's susceptible, rather than saying this is a traumatic thing that happened to her that was done by other people and that caused her to have PTSD. Because we know that PTSD is much more common. It's about twice as common in people who have had a traumatic experience that was caused by other human beings than just, say, a random event, like a car accident or something like that. I think the one thing I would say, thinking about the women who come to us, I think for about 80% of them, the reason they have PTSD is a combination of there was an objectively very difficult birth, with emergencies there in maybe postpartum hemorrhage or a lot of things frequently going wrong, combined with obstetric violence, whether that's, procedures being performed without their consent, or whether it's just kind of the kind of cruelty that happened in your story where they weren't even talking to her or listening to her and people just wandering in and out and talking about their weekend. But I would also say that in a minority of cases, it just can be sometimes the birth itself was very, very difficult and just very traumatic. And there's nothing wrong with the staff. The staff were all fine and helpful, but sometimes, sometimes, just things just go very badly wrong. I'm thinking of one woman I spoke to not so long ago for a training video where it got to this state where the doctors literally had minutes to save the life of the child, and it was kind of very, very fast cesarean, and she was intensely traumatized by it. But she had no criticism of the staff at all. She felt they were all kind of behaved impeccably. So you do get that as well. You do, but it's less common. It's much more common to have the pattern where you have the obstetric violence and a very difficult birth as well, and kind of psychological cruelty. I think that's really important, that sort of psychological cruelty. So I think that's a really interesting debate to have, that kind of shift from it's the woman to, it's the way she was treated during childbirth.
Thank you, Kim. Nice meeting you and all the work you do at the birth trauma that we certainly follow. We've been debating a lot about this. We're actually working on that with Michelle. Maybe she can reply later on this specific topic. Nahia's cesarean was normal cesarean, as you say, it was an uneventful cesarean. So many women have been through such ordeals, and it's considered not so bad that we think this illustrates well this topic. We also know women who had very emergency cesarean for placental abruption or stillbirth, who had such excellent care that even if they suffered the loss of the baby or the loss of the uterus, if they were very, very, very well cared for, it caused grief, but not trauma. And this is very interesting to differentiate both, because yes, birth can turn out really bad, and some women will have to grieve after birth all their losses. The problem, our hypothesis, but obviously we can discuss it, is that the trauma usually comes from the isolation, the lack of care. So the problem with birth is that we do know now the psychological altered state consciousness during childbirth makes it a scenario very, very easy for re-traumatization. So women who have previous been victims of sexual abuse or any type of violence are highly likely to be more easily traumatized. But saying this is nothing about blaming the women. It's about making sure all people, all professionals who take care of birth should be extremely careful. And I think we're really far from that still. At least in my country. So maybe Michelle Sadler, who's in the room, can add something to, maybe she's not in here anymore. Oh, yeah, she's there. Maybe you're there. Maybe you can reply to this.
Yes, I would agree with everything we have discussed so far, but what I think is of utter relevance is to reflect on how far we have gone with the medicalization of birth, and how many of those emergencies are iatrogenic by default, but because of the chain of interventions, so of course there are emergencies that we cannot have anticipated. This will always happen, but it's few cases overall. And what's very worrisome is the amount of emergencies we are creating. So then it's all this discussion of, but it was an emergency. There's so much literature on how emergency during childbirth is creating trauma, no? But then why are these emergencies happening in the first place? And Ibone was mentioning the hysterectomies, the amount of unnecessary hysterectomies of cesareans, it's infinite. Now in Chile, we just got reports. We have been asking for several years for the detailed data for cesareans. The last info we had was 50% in 2017. And now we got the update that after asking by transparency laws, like it took us really hard work to get the data, we have 58% cesareans. And not only that, but the latest 2 maternal deaths have occurred in women with an unplanned cesareans, with programmed cesareans, sorry, with elective cesareans decided by the medical team. And these usually are labeled in medical terms as like, how would they call it? Like this inherent risk in childbirth. You cannot do anything about some women dying, no? But I think we should go much further and say we are killing women, because maternal mortality, and we know the data, is rising in countries where cesareans are rising and when interventions are rising and where infections, and then it's very shocking to see, like when Ibone was showing the reply from the medics again in Spain, no, saying, oh, we did nothing wrong. Even if CEDAW says it's wrong, we did not do wrong. Like, come on, like this has to stop, because it's women's lives at stake, it's babies' lives at stake, and we have taken it too far. So I think this is in the questions that Ibone puts there. What does activism have to do with this? What is our role? Like, what is our and the thing is to push this agenda and to name what we are not naming. It's not like, of course, as Kim said, there are, of course, some cases that would have had a complication in any case, but many of the complications we're seeing are a result of interventions themselves. So how not to name this? This is, I think, a very big ethical responsibility that we have as activists, as to push this agenda forward. And especially to the academic community, because here we are in this cost talks and to reflect among ourselves, because as Ibone was showing some papers, it's our own community which is perpetuating this model of birth being risky, of women having these risk conditions that make them develop trauma because they are, I don't know, hypersensitive, perfectionist, they expect too much, they're not prepared. And some, we have been reading all this literature for some years now with Ibone, and it's really shocking how we can really say, for example, that we should prepare women for being mistreated. There are some papers that say, no, nurses, midwives should work, and women not having such high expectations and not expecting to be really well cared for, because that will not always happen. So this is one of the things that shocks me the most, like how do we as academic community are able to reproduce this kind of discourses instead of and this is something I think it's a very important part of our job too, like to be reading ourselves critically and discussing in this kind of spaces, reading between the lines, saying, whoa, what are we doing here? What are we reproducing here? What do we want to do with it about this?
Katarina, you have your hand raised.
Yes. Yeah, thank you so much for this interesting presentation and for all the comments. I wanted to say many things, but then they were already told. But I wanted to comment on two things, which is about CEDAW and like, is this a recommendation or is it legal binding? I think CEDAW's action is mostly symbolic, which is also very important, right? Even if it's not, so the recommendation will come out and nothing will be done about it. Actually, the government will happily ignore it. Even if you go to Geneva again and you say, what happened? I was lucky enough to be present at Portugal's last session, which was in June this year, and it was very interesting to see what happens there. It's a kind of ritual, you know, between the experts and the government and the NGOs which go there. I was, of course, in that role as an activist, but it was like a committee of 25 people from the Portuguese government. And I was quite amazed by their answers. Like it was kind of, everything is well in Portugal, it's so good. Like they would be asked about this or that, and they would have all the, but we passed this law and it's getting much better. Many times the argument was, it's much better than 20 years ago. You know, like, which is, of course, good, and I'm happy about it. But as an activist, it's like, yeah, but it's not enough. It's like, do I have to die before seeing those changes, right? So we have this urgency as activists that the problems be solved, but things are so slow to change. And in governmental, what I find is that in this sphere of governmental action, it's really low. And then, okay, there's the legal part, the law, that's very important. But of course, that's not actually going to change it, right? This is about worldviews, about values, about ways of doing, corporate interests, etc. All that we know. The second thing that I wanted to say is about the science and about scientific evidence, and Michelle was talking about it now. I'm always amazed at professional presentations, many times by like obstetricians and midwives who already talk about the birth plan and about informed consent, but it's pretty much, the stress is pretty much on preparing women for the worst. It's like the problem is the expectations. It's part of our role to help women manage their expectations, which is also true. I mean, because you as a good professional, you have to, you cannot promise a woman that she won't die in the end. I mean, you know what I mean? It's like, it's not up to you. But that's always the issue. It seems that it's like, okay, the problem is that women now think that they're entitled to anything. And that's crazy, because of course you might die and we cannot do anything about it. And also in Portugal, the mortality rate is really going up now, and we still don't have explanations for that. There's a commission working on that now, because it's really like for the last 4 years, it has really gone up. And there was always this argument about how many women died before the institutionalization of birth. So before, because in Portugal, home birth was the main place of birth up until the 70s and 80s. It was a very late institutionalization. And this was always an argument for, you know, like before it was so bad and now it's so good, ignoring all the other factors that have also contributed to this decrease.
We hear that in Germany. Portugal as an example for in favor of centralization because of mortality rates. Sorry, yeah. I couldn't, it's too strong. I had to.
Well, you know how discourses are, right? You work with what suits you. And actually centralization is still happening. And this is really terrible. Like recently, another mother has died because she had to be transferred to another hospital. She got to one hospital, which was closed with the urgency of obstetrics closed, and she had to go further 50 miles, and she actually died. So it's really serious, this thing. So maternity wards closing down, etc. But I just wanted to say that in another cost action about peripartum depression, I asked in a working group, what is the evidence, what evidence there is connecting mistreatment in birth and postpartum depression. And nobody could tell me. It was really like, we never looked into that. And we're talking like about the experts, you know, mainly psychologists working with postpartum depression. And it's just like, that was not even a research question. And I think we're still in that part where we're still fighting for the recognition that there is systematic mistreatment of women, and this might have huge consequences. And for us as activists, that we're always listening to these horror movie stories, it's almost ridiculous that we have to publish in a paper that like mistreating someone will cause that person's harm, like right? But we've come to a point where we really have to prove it by the scientific methods, you know, just.
Thank you, Katarina. I think it will be very interesting what Yael has to say.
No, I'm listening, and I keep thinking that, you know, I know how to do research about childbirth. I've been doing it for the past 15 years. What I find very difficult is to figure out how to change policy, how to change medical practices. Even mentioning the words obstetric violence in Israel would create a lot of resistance from healthcare professionals. There is, sorry, I didn't introduce myself. My name is Yael Benyamini, and I'm a health psychologist from the Tel Aviv University in Israel. And, there's hardly any birth activism in Israel nowadays. There was a very active group, and the woman who founded that group and was kind of the lively spirit behind everything they did moved to another country, and that group is hardly existent. There are other women's organizations, women's health organizations that also deal with childbirth, but they're not focused on that. So if there was someone, what I kept thinking of, if there was somebody like Nahia who would go all the way and bring this to court, maybe it would raise these organizations' attention, and they would draw together and maybe have an effect. And there was kind of a conference. COVID mixed up all the years and dates. I can't even remember when it was, not so long ago, about it was led by a legal professional, a woman who's a legal professional. So it was about childbirth, but a lot about women's rights and about informed consent and things like that. And I presented some data on that. All women want to be informed. Not all women want to be involved in decision making, but they all want to be informed. And then there was an obstetrician, a male obstetrician, who came up and presented his viewpoint. And it was clear that he walks into the labor ward, into the labor and delivery room, really scared. And he is afraid of lawsuits. He's really scared. He's really scared that something would happen. I mean, he definitely doesn't want a woman to die on his shift. And you see that there's kind of a vicious cycle here because he's so scared, and he was truly scared. I mean, you can see that I could empathize with that part. But the thing is that there's a vicious cycle because he's so scared, he rushes too fast to interventions, and then the woman might be hurt, at least psychologically. And it's very difficult to reverse that cycle, because what happens is that at that point of decision where they have to decide if they should induce, if they should do a cesarean, they never try the other way. They never try to wait more, to see what happens, to see if maybe if you give this, I'm not talking about cases where there's a true emergency because of the fetal's condition. I'm talking about birth that's stalled and the contractions aren't strong enough, and there are so many hours, and the woman is fatigued, and the staff is tired of her complaining, and a combination of things that are not urgent at the level of minutes. And they never try the other way. And if they had tried and said, okay, you know what, let's wait another half hour. Let's wait another hour. Let's wait another 40 minutes. They never try that. So they don't know what happens if they do try that. And what really concerns me is how to get them to try that, how to get a hospital to try to at least for women who want it. Some women at that point would say, yes, just get the baby out of here. But for women who do not want to be induced, who do not want surgery, how to get the doctors to wait and give it a chance. And I think the one other thing is that if I told you the rates of cesarean sections in Israel, you'd laugh at me, because you all mentioned very high rates. In Israel, it doesn't quite reach the 20%. It's almost there. So it's not considered that dramatic. So what am I complaining about? But if you look at the rate of inductions, they're rising rapidly in the past few years. And women's physiology has not changed in the past 6 years so dramatically. or anything else in our world. So inductions are rising. There's an active organization. That one is very active about zero separation. It's called Zero Separation. That's they're activists about everything that happens from the moment the child is out. So no separation from the mother, which is also very difficult to get in some hospitals. So there are other indications of childbirth is highly medicalized in Israel, and it's not reflected in a very high rate of cesarean sections, but it's reflected in the fact that the midwives are there most of the time. The doctors just pop in and out for very short periods of time usually, but they call the shots, they make the decisions, and they're not there they're not in the labor room enough time to even listen to the woman, to take in her wishes into account. And so they make the rules, they enforce them, and they go mostly the medical way. And you know, I'm a psychologist. I'm not an activist. I'm not a policy. I don't know how to influence policy, but it really concerns me. I wanted to hear, you know, to take part in this discussions, because I wanted to you know, get ideas and motivation to look for ways to influence health practices and policy. Oh, and just one last thing that I will say, there are 2 hospitals in Israel where most of the women who give birth are ultra-Orthodox women. These hospitals have half the rate of cesarean, around 10%. So when you want, you could do it. It means, and the physiology of these women and the women who give birth anywhere else is the same. The only difference is that these women want 8 children, 10 children, 12 children. Now you can bear more children after a cesarean, but you know, if you want 10 or 12 children, you'd prefer not to have a cesarean on the way. It might influence your chances of reaching these grand multiparity. And there the doctors know how to handle it. They still know how to do breech birth vaginally. They still have the patients to wait if it's not a fetal emergency. But it doesn't spread. This different birth culture doesn't spread to other hospitals. It's only in these 2 hospitals, because the women who give birth there have different priorities, and they're the majority in these hospitals. So it can be done. And still, it's not done anywhere else.
How interesting. Yeah. Regarding, I'll be very brief, Katharina, if you let me reply. Regarding your question, the United Nations report on obstetric violence is very good at pointing out this issue, that obstetric violence, as Michelle writes very well, it's a structural form of violence. So health practitioners also do suffer from it. And the United Nations report, there's a page devoted to this, to making clear that if we do not take care of the conditions of working conditions of obstetricians and midwives, if we do not give them support and good working conditions, this is not going to improve. And of course, many of them are highly traumatized also, and many of them leave profession because of this trauma. So we have to look at the structural dimension of this problem. Otherwise, it won't change.
You mean also looking at the midwife's experience as someone between the women and the doctors and the ones who are there but are not making the decisions?
Yeah, many of them are also traumatized, or they feel accomplished of this violence. And so there are many things to be done in that area. I think the only way out of this is by taking care also of the mental health of the professionals, facilitating safe spaces for them to share their experiences. And I think that's the only way to change it. It's not only about scientific evidence regarding childbirth. It's also about help them heal, because many of them are also highly traumatized from this system.
And as you said, Yael, like they are so afraid of birth and of what might happen because of what might happen during birth, that they are so defensive. And if they cannot leave that fear in front of the door, and walk in there and be with that woman and that birth, we are not going to change things. So I think the mental health and the trauma they experienced from a professional side in the birthing room is very important, because if you take that trauma into the next birth, we're never going to change things. I think that's really important. And one more thing, because before I give the word to Kim, because you asked how we can change things. And I actually do think that the CEDAW Convention is a big game changer, because the convention, if your country has signed it, is legally binding. It's a legally binding international contract. And it includes state obligation. So the state signs it and says, yes, we will abide by these rules. The drawback is that it doesn't have any punishment things built into it. They can just say, no, you state, you didn't do any good, and we have these recommendations here, and now look how can you can do better. And then it's up to us, the civil society, to go back and say, yeah, maybe they have improved, respecting to, I don't know how things were 20 years ago, but it's still not good enough. And you have to go back and go back and go back. And I think CEDAW works well, but it takes a long time.
So you say I should first look in their website to see if Israel has signed it?
I think I'm pretty sure Israel has signed it. And then maybe you reach out. There is certainly civil society organizations who prepare every 4 years. Israel has to report before the CEDAW committee in Geneva. And the state prepares a report saying how well they did and what they improved, and and the civil society organizations have the opportunity to present a shadow report. You will find them on the CEDAW website as well, and you can also see there who are the organizations that write this report, and join forces with them. That's what we did.
Yeah, we call it, but what you said, we call it in Hebrew something that doesn't have teeth, and a statement that doesn't have teeth, that doesn't have any
yes, exactly, it doesn't have teeth.
But even the statement, having Israel sign it means it's a good starting point. I'll look for that.
Yeah. And one more thing, what I thought interesting when you talked about the Orthodox hospitals is that they respect the women there and their wish to birth in a certain way. But is it really the women they respect, or is it their religion?
It's the women's wishes. I mean, the doctors there are not necessarily religious themselves.
No, but do they respect the women's wishes, or because it's their religion, like their religious umbrella that protects these wishes?
No, I think they truly respect the fact that this woman is planning a very large number of children, which you would hardly find anywhere in the world and in the developed world. And they understand that they can help that happen. And what happens is that's the vicious cycle I was talking about, because in that hospital, at that moment of decision, whether to induce or whether to go for surgery, if it's not a real emergency, they will wait a little bit more, because they have the confidence that if they wait, it might actually work out. And that's what happens. If you wait patiently and you don't put additional stress on the woman, often labor continues and she does give birth vaginally. But that's the point where the doctors in other hospitals don't go beyond that point, so they never know what happens when they do go.
Thank you. Kim.
Yes, I think the key thing for me is informed consent. And looking at Nahia's story, the most important thing, it seemed to me, was not that those interventions were carried out, but that they were carried out without a consent. The induction, the vaginal examinations, the cesarean, the fact her baby was taken away from her. Nobody seems at any point to have asked her what she wanted to do. So, with the induction, for example, they could have said, we would like to induce you because, there's X% risk of an infection. say if you're not induced. But the alternative is we could wait 24 hours and see what happens, and then she could have made her decision and she would have felt respected. And I think that's the case all the way through labour. You can say, these are your choices, this is what we think should happen, but it's your decision because you assess that risk. And I think with the cesarean, everything she said about that cesarean was to do with things like her husband wasn't allowed to be with her, she was strapped to a table, they had people coming in and out of the operating theatre, they were ignoring her completely, they were talking over her head about their own kind of business, and she was disrespected and treated as if she wasn't important. And you could do, it doesn't have to be like that. So it sounds like it wasn't the cesarean per se, but the way she was treated as if she was less than human. And that was the really traumatizing thing, which is not to say, I'm not saying she should have had the cesarean or she shouldn't, because I don't know the kind of medical situation. But if she had been treated in a more humane way, then that would have made a big difference, I imagine, to the way she felt about it. And I think the one thing I'd say about cesareans, I know a lot of people are very keen on reducing cesareans, and the rates of 50 and 60% do sound very high. But we also hear stories where women have kind of pleaded for cesareans and been denied them and have ended up having very traumatic forceps births, which, it's not a forceps birth, it's not a lovely natural birth. It's really traumatizing, often very traumatizing and difficult. Woman often has injuries afterwards, and as the baby has injuries. So I think you always have to bear in mind what the alternative is. Sometimes it's not as if it's not as if everybody's going to have a lovely natural birth if you postpone the cesarean. Sometimes it can end up badly in another way. And for me, informed consent is key, and sort of treating the woman with respect and as a human being in the way that we would all want to be treated, I think, in a medical situation. Those are the really important things, and the things that we have to address.
I agree with you, Kim, but I think in this case also, if one decido sentence had come out, the Basque public health system would have apologized a bit. I think that would have made such a difference. Like, sometimes the only thing a woman wants is that. That's why I think we should include this idea of restorative justice in the models of treatment for PTSD. Because for so many women, that is so healing, that a health provider or the health system or the hospital director or whomever says, okay, we hear you, we're sorry we treated you like that, we understand that you feel traumatized. That would probably take off so much weight of that heavy burden,
Yes.
like just...
Yes.
That's what shocks me the most, that even after a CA sentence, they still say, no, we did everything correctly. It's like, are you so inhuman? You cannot say, you're sorry, That's...
Yeah. I mean, I agree with you absolutely about that. And one of the things we hear from women a lot is they make a complaint to the hospital, and then the hospital will do a kind of letter, which is, oh, I'm sorry you felt that way, but the doctors did what they thought was necessary. And a lot of them say exactly that. If only they had an apology, we shouldn't have treated you like that, they would feel so much better. Because it's that kind of, I suppose, gaslighting, really, that kind of denial of what happened, that the woman is at fault for feeling upset when she shouldn't have felt upset, and it wasn't the hospital's fault. And they often quite often lie about what happened as well. They'll say that she gave consent when she didn't give consent. All of that, really. And sometimes women take legal action just to have that kind of sense of justice. If the initial complaint's been met with an apology for treating them like that, they wouldn't have felt the need to take legal action, and they do it just to get that sense of justice. So there's a kind of huge area there, I agree with you, that needs improvement.
Not just an apology, but also an opportunity to learn. Like, if they would tell the woman, listen, thank you for letting us know that, we will review your case and see what can we improve, that would make such a huge difference. I think.
Oh, definitely. Absolutely. Yeah. 100%.
But if you allow me to interrupt, I think one of the reasons the institutions never do that is exactly the legal part, because if they will be saying, yes, you're right, we did the wrong way, they are liable. They they will be admitting that they that they didn't abide to the law. So they are confessing a crime, let's say, you know what I mean?
But what I wonder always, since we're having this discussion within the cost section for birth trauma and perinatal mental health, and as a research network, is that actually proven that if, medical staff say, and it's so often they didn't even do a medical error. It's like they failed on the humanity side and on the respectful care side.
But isn't that a medical error? Isn't like medical care supposed to be respectful?
Yes, but it's very often not in the protocols. And as was shown in Nahia's case, they didn't abide by their own protocol, and that is why you could actually have the legal case. But it's so often not about that. It's so often more about the restorative justice and have not only the apology, but also the sense and the urgency to want to protect the next woman. I don't want this to happen to anybody else. That's what's actually, is a big movement, I think, to women who experience that. And I really want to see those figures, if it's actually true that if a hospital says, yes, I made a mistake, maybe not so much a medical mistake, but I erred on the, on the human side, on the respectful side. And I would really like to learn from this, if that causes legal action. I still want to see those figures because I do not believe it. Jota, and then I think our time is basically up, right?
Yeah, thank you so much for organizing this. It gives me a lot of food for thought. And it was really interesting.
Yeah,
Thank you.
we thank Katarina and Ibone. I just wanted to say about your question, Ibone, that many times from our experience, we see women that they are traumatized by birth. That's what they feel. But if you talk to them, you realize that they have an idea of birth in their mind that they think it's traumatizing, but they are traumatized by things like vaginal exams. They're traumatized by forced to birth in their back, by the doctors pushing on their belly, by episiotomies. But this is not in the nature of birth. This is the actions of the health professionals that they don't ask for their opinion. They push on their belly, and I mean, we have a woman that she had incontinence, and the doctor put how you say this? I'm not sure. The cap that suctions the baby.
Vacuum.
But before, yeah, but before she was in full dilation, and there was actually a fight between the midwife and the doctor. He was like, "I know what I'm doing. Like, don't do it. She's not fully dilated yet." And then, of course, the woman was traumatized by birth, and she chose to have a cesarean for her next birth, obviously. But if you see it and if you talk to her, after many years, because that was like 6 or 7 years ago, she now realizes, but that she at the time she was traumatized by vaginal birth, but now because she knows better, she researched it. She realized that it was the actions of this doctor. It wasn't the birth itself. And I just wanted to add this, that many times women say it's the vaginal birth or it's the cesarean, most times. But then you find out after some years, when they are more out of it, when they think of it more from distance, And I also wanted to say about what you said, or Katarina said, about the loss and bad things that do happen, that it's indeed a different trauma, if I can say, and different thing. If you feel that what happened was not the fault of someone, and if you were not downgraded, humiliated, we are grown-up women. We know that life is not only happiness, that there is loss, there is death, there are bad things like accidents or hemorrhages or whatever. And of course, you're traumatized at first, but I think, for me, because I did have a loss and a bad experience, obviously, it is different. What has stayed now, it's how they made me feel, and not the loss that, it's the grief that makes its cycle and it closes. And of course, there is always grief, but it's grief. It's not anger with somebody. It's not feeling still traumatized. I don't know how to say it when you think about the birth.
Yeah, Jota, thank you for this point. I think this what you explained closes very well this discussion. We've been using the analogy with rape. We say PTSD following rape. We don't say PTSD following intercourse. Intercourse doesn't have to be traumatic, but if there's no consent, then we talk about rape. And that's why we want to change the conversation. And we want to talk about PTSD following abuse or mistreatment or obstetric violence during childbirth, because it's not the childbirth per se. And your examples were fantastic. So I'm very happy to thank you for it. And to close it here, Katarina, you want to add something?
No.
Oh, I forgot to say, I will be happy to share the PowerPoint within the cost devotion group as well.
Yes,
Yeah.
thank you.
I'm very happy we made this happen today. I'm very happy. And I hope that this video will be watched by many, many people, and that we can get the message across that the two concepts of birth and obstetric violence are so entangled at the moment, and we have to disentangle them, because it's not birth that women are traumatized by like that. And there's a huge difference between grief and trauma. Yeah, amen.
Thank you, Katarina.
Thank you all so much.
Thank you, everyone.
Thank you.
So you want to stop the recording then, Ivona, maybe?
Yeah.